When we talk about nerves, upper limb nerves are more commonly asked than the lower limb nerves. And when we look at which is the most common nerve asked, radial nerve. Radial nerve is also the most commonly damaged nerve, and it is also the nerve with the best prognosis. Usually it goes like this: common things have a better prognosis. When I look at my anatomy lectures, I would see these images of distribution of sensations along upper limb and lower limb. I will mug it up for hours, but at the end of the day, I won't remember it. So is there a way that we can remember the major sensory distributions of 3 nerves of upper limb? Yes. And the way to remember is this. This is like a horn, also called as horn sign. Now, anybody who can do that, it means that all the 3 nerves are intact. The radial nerve, the ulnar nerve, and the median nerve. When I look at sensations of upper limb, the tip of little finger is supplied by ulnar nerve. It is an autonomous zone, exclusively supplied. The tip of index finger is supplied by the median nerve. And the dorsum of the first web space is radial nerve. So this is ulnar, median, radial. So these are the 3 nerves that we must remember. Also remember, radial is the commonest damaged nerve and has the best prognosis. This image doesn't belong to people like me. I will remember this sensory distribution. Majority of my questions will be answered. Classification. Seddons classified nerve injuries into 3 types. Seddon's neuropraxia, it's a physiological block in the nerve conduction. There is no anatomical damage. There is 100% recovery. What is more important to remember? Supposedly, I have a radial nerve palsy. I will have a wrist drop. If it is neuropraxia, it will get correct on its own. Tuck. So there is no gradual improvement. It is like a moment. Like love strikes in a moment, in a flash. Similarly, neuropraxia occurs in a flash. It comes back like a lightning. And lightning will strike at one go. Axonotemesis is a damage to the axon sheath. It recovers from proximal to distal. Example, radial nerve palsy, loss of elbow extension, wrist extension, finger extension. When it will recover? First the elbow, then the wrist, then the finger. This is proximal to distal, also called as motor march. What does not recover is neurotemesis. But you will mention in all these, there is a mention of Tinel sign. Let's understand what is Tinel sign. When we talk about comparison of Seddons to Sunderland classification, Seddons neuropraxia is Sunderland type 1 injury. Seddon's axonotmesis is Sunderland type 2, 3 and 4. And Seddon's neurotmesis is Sunderland type 5. So when I compare them, the relationship is like this. Seddon's is a small word. It has 3 stages. Sunderland is a bigger word. It has 5 stages. Although Sunderland type 4 is classified by 2 and 3, but prognosis wise behaves as type 5. So 4 behaves as type 5. 1 is like neuropraxia, 100% recovery in one go. 5 is classical neurotmesis. 4 classified with axonotmesis but behaves like neurotmesis. Also remember, it is according to the sheaths from inside to the out. And the sheaths of the nerve is endoneurium, perineurium, epineurium. So E is inside, endo, and epi is the most peripheral. So in nerve injuries, remember, same alphabets don't come together. Neuropraxia, then axonotmesis, then neurotmesis. So it is N, then A, then N. People sometimes reverse it. Similarly, it's endo, peri, then epi. 2E doesn't come together because people get confused. Epi is above peri or peri is above epi. So don't confuse that. Now I told you we will talk about Tinel sign. Tinel sign is based on law of projection. Tinel sign tells you about the recovery. So what is law of projection? Law of projection says if you stimulate a nerve, you can't stimulate a nerve. When you touch a receptor. So law of projection says if you stimulate a nerve, you can only stimulate a nerve when it's damaged. You can't stimulate a physiological damaged nerve. So neuropraxia is not a part of this discussion. So you will stimulate an anatomically damaged nerve. An anatomically damaged nerve where there's a damage to the myelin sheath that can be stimulated. So law of projection says when you stimulate a demyelinated, anatomically damaged nerve anywhere along the path, the brain will perceive that the stimulus is coming from the area of the receptor, even if the receptor is not in the body. I'll give you an example. If you look at the tip of index finger, this is supplied by the median nerve. So if I look at my median nerve supply, that's how it travels. Imagine the median nerve got damaged in this area. Anatomical damage. There are free nerve endings. So when I tap on the course of the nerve from distal to proximal, the moment I strike the free nerve ending, it will be stimulated. Stimulated. Nerve stimulated will stimulate the brain center for the median nerve, and the brain will project that the stimulus is coming from the receptor. You are hitting at the free nerve ending. But law of position says if you stimulate a nerve, the stimulus brain will perceive is from the receptor, which is the tip of index finger. So you will feel the abnormal sensation of tingling here. Tingle, tingling. You will label it as positive. You will ask the patient to go back home. He will come back after an interval of 3 weeks. When he comes back, you will repeat the test again. There can be two scenarios. Scenario number 1, the nerve did not recover, neurotmesis. So when you will go from distal to proximal, you will again strike at the same point, tingling again at the tip of index finger. You will say it's positive at the same point, called as positive but static. In other words, if the nerve recovers, it will recover from proximal to distal. When you strike again, now there is a new point, because the myelin would have covered the recovered nerve. So the tip is demyelinated. Now you have a positive point, you strike here, brain stimulated, tingling felt here, is distal now. You know the distance between the 2 points, that's the distance. Divided by time, distance upon time is equal to speed. This will tell you the speed of nerve regeneration, which is 1 millimeter per day as satisfactory, or you can label it as 1 inch per month. An inch is 2.54 centimeters or 25.4 millimeters, almost roughly 1 mm per day in a month of 30 days. So good rate of recovery is 1 mm per day. So when I look at Tinel sign, in neuropraxia, since it's a physiological block, it's not applicable or negative. In neurotmesis, it is positive but static. In axonotmesis, positive and progressive. So if they ask you, Tinel sign is positive in, 2 answers are correct, axonotmesis and neurotmesis. But if you have to choose one answer in an exam where single best answer is there, you will take it as progressive being really positive means axonotmesis. Let's talk about nerves. Let's go to the first nerve, the axillary nerve. Axilla, axillary nerve. It takes a turn at the proximal part of the humerus and supplies this area. Army people, they apply a badge here, the regimental badge. This area is supplied by axillary nerve. If there is a damage to the axillary nerve, you will have loss of sensation at this area. Axillary nerve supplies 2 muscles, deltoid and teres minor. Remember that. These 2 muscles and the sensation. Axillary nerve can be damaged in 3 types of injuries. Number 1, shoulder dislocation, anterior, posterior, inferior, anything, axillary nerve. Number 2, fractures of the proximal part of the humerus. And number 3, intramuscular injection into deltoids. This is the regimental badge area. Regimental badge sign. When I look at the lumbricals, one of the muscles which the examiners love, we have 4 lumbricals in each hand. The lateral 2 are supplied by the median nerve. The medial 2 are supplied by the ulnar nerve. Lumbricals, they make a L in your hand. So they will make a L. This action is of lumbricals. Flexion of MCP, extension of interphalangeal joint. This is also called as intrinsic plus position. You remember Kapil Sharma? He made a show, Comedy Nights with Kapil, and he said this, took. This sign, took, very famous. I should not be speaking it here, is action of lumbricals. Every doctor forgets it. You must not. Lumbricals, if they are paralyzed, opposite will occur. Look here. Hyperextension of MCP, flexion of interphalangeal joint. This is called as claw hand, clawing. Lumbricals, clawing. When you apply a splint and replicate the L, you are bending the knuckles. This is called as knuckle bender splint. Median nerve, ulnar nerve, paralyzed, action gone, claw hand, correction, knuckle bender splint. So they had shown in one of the exams, first lumbrical marked in a cadaveric specimen, and they asked you which nerve supplies it. Answer, median nerve. When I look at the interossei, in my hands, I have palmar interossei, 4 of them, dorsal interossei, 4 of them. Palmar adduct. So palmar interossei, they adduct, adduction towards the middle finger. Dorsal, abduct. Dorsal interossei, abduct. And friends, the middle finger does not have palmar interossei. That is why its movement to either side is called as abduction. So pad, palmar interossei, dorsal interossei. All the interossei, friends, are supplied by ulnar nerve. Remember that. All interossei, ulnar nerve. Let's talk about ulnar nerve. Ulnar nerve will supply the palmar interossei. So if you give a card to the patient and ask him to hold it between the fingers, just like this photograph here, this is card test. The examiner also will try to pull it out. And if your palmar interossei is strong, he will not be able to do that. So card test, palmar interossei, ulnar nerve. Similarly, if you ask a patient to place his hand on the table and move the middle finger to either side, if he is not able to do that, this is Igawa test. Igawa with I, not E, dorsal interossei. Friends, when we look at the thumb, our thumb, it is thenar eminence which supplies the muscles. Among the thenar eminences, one of the muscle is adductor pollicis, supplied by ulnar nerve. Adductor pollicis adducts the thumb. The movements of the thumb. If I get my thumb into the plane of palm, it's flexion. When I get them away, it's extension. When the thumb is by the palm, it's adduction. When the thumb is right angle to the plane of palm, it's abduction. When it touches all the fingers, it's opposition. When it rotates in all the planes, it's circumduction. So, adductor pollicis supplied by ulnar nerve. If I give a book to a patient, ask him to hold it between the thumbs. If he is able to hold it, it means adductor pollicis is functioning well. And if it's paralyzed, nobody will let the book go. So the patient will flex the thumb and hold the book. So when you are able to hold the book, it's book test, adductor pollicis, ulnar nerve. And when you have to flex the thumb to hold the book, this movement. Then the long flexor of the thumb, flexor pollicis longus, is substituting for adductor pollicis. This is Froment sign. Friends, Froment sign, many people confuse for median nerve. But friends, Froment sign is for ulnar nerve. I will tell you a mnemonic. You may laugh over it. But the mnemonic is FU. What is FU? Don't laugh. Keep your mind pure. FU means follow up. Follow up means ask the patient to come back to you. Please don't think anything else. I am a teacher. I am supposed to tell you good things. So mnemonic is FU. You can pause the video, smile and start again. So from and sign, ulnar nerve. Flexor pollicis longus is supplied by anterior interosseous nerve, a branch of median nerve. We'll come back to it shortly. And when the ulnar nerve is paralyzed, your little finger stays abducted. This is Wartenberg sign. So card test, book test, Froment sign, Wartenberg test, Igawa test. These are 5 tests you should remember for ulnar nerve. But if you want to remember one, Froment sign. Ulnar nerve will cause the ulnar claw hand. The median nerve can involve the median fingers, and all the nerves involved causes total claw hand, means ulnar and median. When I look at the ulnar claw hand, I want to talk about the ulnar paradox. What exactly is ulnar paradox? Ulnar paradox means that the amount of clawing is dependent upon where the ulnar nerve got injured. You can have an ulnar nerve injury right around the elbow. Behind the medial epicondyle, the ulnar nerve goes. Or you can have an ulnar nerve injury right around the wrist. So around the wrist, around the elbow, anywhere. Around the elbow, it's called as high ulnar nerve palsy. Around the wrist, low ulnar nerve palsy. Now, when you have ulnar nerve injury around the wrist or around the elbow, the difference is around the elbow, the medial half of flexor digitorum profundus, the long flexors of the fingers, is supplied by the ulnar nerve. When the injury occurs around the wrist, because FDP has been supplied around the elbow, it is spared. Let's understand the difference. Imagine you have an ulnar nerve palsy. Lumbricals are gone. You have clawing. Now, if the injury is around the wrist, you know the long flexors of these two fingers, FDP medial half, it will contract and cause more clawing. So ulnar nerve injury around wrist will have clawing, proper clawing. But if the injury occurs around the elbow, the FDP is also paralyzed. So the clawing will be less. Surprising, no? When the injury is more proximal, you should have more damage. Example, brain injury to finger injury. Brain injury will have more damage. But in ulnar nerve injuries, around the elbow, although damage is more, but the clawing evident is less. So, elbow injury, high ulnar nerve injury, less clawing. Wrist injury, low ulnar nerve injury, more clawing. So, ulnar paradox. Injuries around elbow have low clawing, or high ulnar nerve injury has low clawing, less clawing. So this is you should remember. Coming to the median nerve. You know the median nerve helps you make the fist. When you make a fist, what all are you using? FDS of all the 4 fingers, FDP of all the 4 fingers. FDS of all the 4 fingers is supplied by the median nerve. FDP of the lateral 2 fingers is supplied by anterior interosseous nerve. The medial 2 fingers is supplied by the ulnar nerve. Anterior interosseous nerve is a branch of median nerve, and ulnar nerve for the medial 2. Making a fist, FDS and FDP. Imagine your median nerve is paralyzed. So the flexors of these two fingers are gone. So when you make a fist, they will stand out. But these two, the ring and the little finger will flex because of FTP intact. You know, when you make a fist and you have a median nerve palsy, these two fingers stand out. It's called as the pointing index. The word is very simple, pointing. But it should be like this because these two are not being flexed, but it instead is half flexed middle finger. Why? Because the tendon sheath of the ring finger and the tendon sheath of the middle finger, they are common. Whereas in humans, the index finger has separated out to work with the thumb. So, friends, let's do it slowly, as if Shah Rukh Khan is running to meet Kajol. Slowly. Flex these two fingers. All of you do it with me. When you do that, this moves. You can't keep it straight. Do it again. And you know, when this moves, how much will it move? Will depend upon how much connections we have to each other. We move for a person depending on connection. In some people it will move too much, some less. But there will be some movement. Can't stay. So the middle finger and the ring finger, common tendon sheath. That is why in pointing index, the index finger is straight. Because in humans, we have separated tendons of index finger. Whereas the middle finger is partially flexed. That's how you should remember. When a pope talks to a big community, that's how he speaks. This is called as benediction attitude. Or when you hold your palms like this and you make a clasp, you are making a fist in both the palms. This is the same as pointing index. If your median nerve is paralyzed, these two fingers will stand out. This is called as the Ochsner clasp test. Pointing index, benediction attitude, Ochsner clasp test, they all mean the same. Inability to flex these two fingers. When you give a pen to a patient, ask him to touch it with the thumb. This is abductor pollicis brevis. Median nerve supplies it, called as pen test. If your median nerve is paralyzed, you will not be able to touch the pen. And then, friends, the opposition is a gift of median nerve to human beings. Thumb opposes. That's why we are specialized. Monkeys, they can't do this. That is why their thumb is in the same plane as palm. This is called as ape thumb deformity, median nerve. How will you remember it? People remember ape thumb deformity with respect to radial nerve. Remember my name, Apurv Mehra, AM. So ape thumb, median nerve. मैं बंदरों जैसे काम कराता हूँ. So ape, median nerve. Don't write this down. Just remember. Ape, monkeys, thumb, median nerve, AM. So two things to remember. Ulnar nerve, remember FU. Median nerve, remember AM. And then we know that the anterior interosseous nerve is a branch of median nerve. It supplies three muscles. Whatever has got three things is an MCQ. It supplies flexor pollicis longus of thumb, FDP lateral half, and pronator quadratus. So, this sign called as OK sign, also called as Kilo-Nevin sign, will only be possible in a patient if his anterior interosseous nerve is intact. Ulnar and median nerve palsies, they cause claw hand, and correcting them produces the knuckle bender splint. So friends, if you have claw hand and to correct that you have a knuckle bender splint, and since ulnar nerve is more common than the median nerve injuries, if they give you both the options, for which do you use knuckle bender splint, ulnar nerve is a better answer. So this was about ulnar and median nerve.